Hi, everyone. I'm Dr. Valerie Flores. Apologies for the slight delay. I was in a procedure. I'm just going to wait a few more minutes to let a few more people join, but I'm excited to chat with everyone today. Okay, looks like we have a good number. So let me go ahead and share my screen. Okay, great. So as I mentioned, I'm Dr. Valerie Flores. I'm one of the fertility specialists here at San Diego Fertility Center. Just for those of you who may not know a bit about me, I'm originally from Southern California, but I completed most of my training on the East Coast. I was at Yale for medical school, Brown University for residency in OBGYN, completed my fellowship in reproductive endocrinology and infertility at the Yale School of Medicine, and then actually stayed on at Yale for a few years as a physician scientist before returning to Southern California, which I consider home. And it really gives me so much pleasure today to talk to all of you about Pathways to Parenthood. It's a fertility webinar. And of course, at the end, I am more than happy to take questions. So I just wanted to go through a little bit of an outline in terms of how we approach infertility and just some additional information that I'm going to be providing. So first, we'll talk about when to see a fertility specialist. Then we'll go through fertility testing, fertility treatment options, and also talk a little bit about fertility preservation. So when do we recommend that you should see a fertility specialist? That really kind of depends a bit on age. And that's because really, unfortunately, as women, we do have a bit of a clock when it comes to our fertility potential and the number of eggs that we have. Our peak fertility is in our 20s. By the time we're in our mid-30s, the likelihood of getting pregnant each month drops to about 15 to 20%. By the time we're in our 40s, the likelihood of getting pregnant each month is around 5%. And by our mid-40s, it has unfortunately dropped to 1%. So based off of these percentages, we usually recommend that in individuals who are less than 35, we recommend seeing a specialist after 1 year of unprotected intercourse. And that's because after 1 year of trying, around 85% of couples should be pregnant. Once we get to be over the age of 35, we recommend seeing a fertility specialist after 6 months of trying. And then those who are 40s or higher, we recommend more of an immediate evaluation. And again, that's based off of studies showing that unfortunately, when we're in our 40s, the likelihood of getting pregnant each month, even in the absence of infertility, is around 1%. But I do really want to highlight and recognize that infertility, unfortunately, is very common. A year ago, we said that it was affecting 1 in 8 individuals. Now we know that it's actually affecting 1 in 6 individuals. And so it's important to recognize that you are not alone. I know that fertility treatment or infertility can seem very isolating, but we, as your fertility docs, are here, and there are a lot of communities that are really focused on promoting, one, fertility and increasing awareness, but also recognizing that you're not alone and helping you seek the appropriate care when you feel comfortable seeking that care. So this slide really is talking, again, a little bit more about the decline in fertility with age and why there's that decline. So one component is the number of eggs that we have available over time, unfortunately, declines. So women, again, as I had mentioned before, we're born with all of the eggs that we're ever going to have. We unfortunately don't make new eggs. By the time we're born, we have around 1 million. By the time we hit puberty, we're actually down to 400,000 eggs, and we lose them each month/each year. And so what's further compounds that is that actually, as we get to be in our late 30s, early 40s, the quality of our eggs declines, unfortunately, as well. And quality is really referring to the ability of the egg to divide properly so that it has the right number of chromosomes in it, so that ultimately we have the right number of chromosomes in an embryo. So you can see in the purple, our fertility potential in our 20s is close to 100%, and then that starts to decline as we age, unfortunately. And then what also happens is that unfortunately in the green, the risk of miscarriage starts to increase. And in fact, when we are less than 35, around 25% of our eggs can be chromosomally abnormal. So no person has all normal, chromosomally normal eggs. Around 20% still can be abnormal. Once we get to be over the age of 35, around 35% can be abnormal. So it's a 10% increase. And that's where this concept of advanced maternal age came, which is not a term that we like to use, but just I'm sure individuals have heard about it, so I just wanted to kind of explain where that terminology came from. And then by the time we're 38, up to 50% of our eggs can be chromosomally abnormal. And then once we're in our 40s, around to 60 to 70% can be chromosomally abnormal. And to highlight, I don't want to make the point and make this be, a bit of a downer type of talk. I just want to give you the information so that you know, and so that when you're thinking about family planning or an infertility or fertility evaluation, these are the things that your doctors are thinking about too when we're thinking about treatment options. There are also some situations where we recommend seeking evaluation earlier, and that's for individuals who have irregular periods, because in those situations, ovulation may not be happening every month. Individuals who think or know that their fallopian tubes may be blocked, or if they no longer have their fallopian tubes, since that's ultimately where the egg and the sperm usually meet. Individuals with endometriosis, individuals who have difficulty with intercourse, or for heterosexual couples with a male partner, if there's a history of testicular injury or varicocele in the male partner, or testicular cancer. So what does the testing entail? So one is looking at the eggs, looking both at quantity and quality. The next is looking at the uterus and the fallopian tubes. And then for men, looking at the sperm. So what are we really looking at when we say that we're going to be quote unquote testing the eggs? These are mainly focused on both blood testing as well as imaging testing. For blood testing, we would check an anti-Mullerian hormone, or AMH. That's the hormone that's made by the eggs in the ovaries, so it's a good indirect indicator of how many eggs you have. Not literally, just more for your age, is it a good number or a low number? And on average, usually 1 is considered a normal number. We also look at FSH and estradiol levels. FSH stands for follicle stimulating hormone. That's a hormone that's made by the brain, and it's normally telling the ovary that it's time to release an egg or start growing an egg to ultimately have the egg released. Estrogen comes from the growing egg, and so we normally test FSH and estrogen on cycle days 2, 3, or 4, because at that point, the values actually should be low, and it's the one time low values are good. It's an indicator that the brain and the ovary are communicating well with each other to say that it's time to grow and release an egg each month. On the ultrasound, we're looking at what we call an antral follicle count. So you may have, if you've ever had an ultrasound done, you may have heard us talk about counting the eggs. It's a bit of a misnomer. We actually don't see the eggs because they're microscopic, but what we do see is the fluid surrounding the eggs, and we call that fluid-filled sac a follicle. And so we count all of the follicles, and that's a representation of the cohort of eggs that you have in a given month. It's not how many you have left. I cannot emphasize that enough. It's more of an indicator of how many eggs you have or follicles you have that month, and it should be similar from month to month over the next couple of months to a couple of years. The other point actually of imaging is to look at the uterus. And so that we usually do again with a transvaginal ultrasound. And so here, this top image, this is the entire uterus here. So this is the top of the uterus going towards the cervix. And then this wider area where you can see these little calipers, that's the lining. So that's ultimately where implantation will happen. Sometimes you can see what looks like a polyp or a fibroid in the lining of the uterus. So polyps are benign, meaning non-cancerous overgrowth of the lining of the uterus. Polyps are benign, non-cancerous overgrowth of the muscle layer of the uterus, which is this layer right here. Not harmful per se, except in the setting of couples who are trying to get pregnant, because both polyps and fibroids can make it harder for the uterus to undergo all the changes it needs to undergo for implantation purposes. And if we see something like that, we usually recommend what we call a saline infusion sonogram. So here the black is saline or something similar to water that we're putting inside the endometrial cavity. It serves as a really good contrast to really confirm whether or not a polyp or a fibroid is present. And if it is, we talk about removing that. It's a minimally invasive surgery prior to pursuing fertility treatment. With respect to fallopian tube evaluation, the more common way has always been hysterosalpingogram, where a water-based dye is placed in the uterus, and then x-rays are taken to see whether or not that dye actually makes it through the fallopian tubes. So here is an x-ray image of the pelvis. This is the catheter. And then this triangular shaped area is the uterus. And the little string-like areas here are the fallopian tubes. And then you see the dye making its way through the fallopian tubes. We actually have office-based procedures as well, where we can put a bit of a foam through the uterus and with an ultrasound, see that foam going through the fallopian tubes as well. In terms of a semen analysis or sperm evaluation, what we're really looking at is sperm number, how many of the sperm are moving or motility, and the morphology. So how do the sperm look? And so here there's an image looking at what a normal sperm should look like, as well as a couple of abnormal forms. But normal is one oval-shaped head and one tail. And what we're looking for is really on average, we want to see around 15 million sperm. We want to see that over 42% of them are moving and that about 4% of them look like this with the one head, the one tail. Samples also can be collected at home, by the way. So the sample can be collected in the office or in male partners who would prefer collecting at home. That's absolutely okay as well. So now I wanted to talk a little bit about what are some infertility causes. One of the more common forms is unexplained infertility. We as a community are working on changing that terminology because you're coming to us looking for an answer for why pregnancy may not have happened. And when we say things like unexplained, it's implying that we don't necessarily know. But really what unexplained means is that we know that the female partner has eggs, we know that the male partner has sperm, the uterus is normal, the tubes are normal. For some reason, it's most likely that the egg and the sperm are having a little bit of trouble meeting. And I'll go into it a little bit later in terms of what the treatment options are for that. Some other causes of infertility are ovulatory dysfunction, so perhaps individuals who are not ovulating every month. Male factors like low sperm number, for example, may be contributing, or low motility, or more abnormal forms and normal forms of the sperm. And then we also look at tubal or pelvic factors, so whether or not there's any damage to the fallopian tubes, or thinking about patients who may have endometriosis or adenomyosis. But based off of the cause, the treatment options that we would recommend are either ovulation induction with or without intrauterine insemination, and or considering in vitro fertilization. And how we decide who needs what is based off of what those fertility tests actually show us. But I do want to go through just the two different treatment options in general, just so you have a better idea of what those are. So ovulation stimulation can be done with either oral medications or injectable medications. The two that we typically use are clomiphene citrate or letrozole. Both essentially work by tricking the brain into thinking that the estrogen levels are low, and in doing so, get the brain to essentially work harder to tell the ovary to make an egg. And usually in doing so, have the ovary grow about 2 eggs in a given cycle. Injectable medications consist usually of a combination of FSH and LH, the two hormones that the brain already makes to tell the ovary to make an egg, but we utilize the injectable forms because they're synthetic versions. They allow us to give higher doses to allow for, again, more than 1 egg to grow. We also usually will trigger ovulation to happen once the follicles reach a size where we think that there should be a mature egg. And that's just really helping to ensure that ovulation with almost 100% certainty is going to happen. And then we can combine that with an intrauterine insemination. So this is a process by which the male partner provides another fresh sperm sample, again, that can be collected at home. It's processed, so it's washed and concentrated into a catheter, which you can see here on this right side, or rather to a syringe. So the sperm is concentrated into the syringe, connected to a little catheter. That catheter is threaded into the uterus, and the sperm is deposited at the top of the uterus. And so these two things are doing two things. One is it's increasing the number of eggs that are available to be fertilized by sperm. And two is it's bringing the sperm closer to the egg. So the sperm can bypass the vagina, the cervix, and be placed closer to the uterus where it can ultimately meet up with the egg in the fallopian tube. So who is a good candidate for ovulation stimulation and IUI? Individuals with unexplained infertility, because remember, we talked about how we think that, yes, there are eggs, yes, there are sperm, the anatomy is normal, but for some reason the egg and the sperm are having trouble meeting. So again, with the ovulation stimulation, now we're getting 2 eggs to be released, increasing the likelihood that at least one of the eggs is being fertilized. And then on top of that, we're bringing the sperm closer to the egg. Ovulation stimulation, or actually here it's called ovulation induction, it also is helpful for individuals who have irregular menstrual cycles, so those who are not ovulating regularly. One of the more common causes is polycystic ovarian syndrome, but in these individuals, it's truly induction because normally ovulation is not happening on their own. Individuals who have low sperm count or low motility, because again, with IUI, we can actually concentrate the sperm. And so we ultimately increase the number of sperm that's actually making it into the uterus. And it's also a good treatment option for same-sex female couples. IUI is for those using donor sperm. The requirements are really that the fallopian tubes are open and that we have a good number of total motile sperm. So yes, IUI helps to overcome what we would call mild nil factors. So if there are slight decreases in sperm concentration or motility. But ideally, to have a good likelihood of success with IUI, we normally recommend that we have around 9 million sperm in a given IUI sample. And that's something that as we review in a follow-up appointment, the results of the semen analysis, we can go through not just the count, the motility, and the morphology, but we'll also go through what the total motile sperm count is as well. So what's the likelihood of pregnancy after ovulation stimulation? So we usually talk about this in terms of after 4 cycles of IUI, and that's because most of the studies have really looked at up to 4 to 6 cycles. So with each IUI cycle, or with each ovulation stimulation with IUI cycle, the likelihood of getting pregnant does increase. So not everyone gets pregnant on the first cycle, but although it can be disheartening, of course, to not have a positive pregnancy, it is important to recognize that the likelihood goes up with each IUI and ultimately goes up to about 20%. With injectable medications, it's a little bit higher, it's around 32%. Although we usually try to reserve injectable medications for those who don't respond to the oral medications, just because the risk of twins is also much higher with injectable medications. And then rates, unfortunately, are lower for couples who are in their late 30s, early 40s. Another treatment option that is available is in vitro fertilization. So this is a little bit more of an involved process. Here we intentionally give injectable hormones, again, a combination of FSH and LH, and these are daily injections. And again, we're taking advantage of the fact that with these synthetic versions, we are able to give higher doses to maximize the number of follicles or eggs that we're getting to grow and ultimately retrieve. And that's because now we don't want just 1 or 2 eggs to grow in a given cycle like we were with ovulation stimulation. Now we intentionally want to get as many eggs as possible because ultimately we're going to retrieve those eggs and combine them with sperm. So the first step is ovarian stimulation, so daily injections for, on average, 10 to 12 days. This culminates in an egg retrieval. So again, trigger shots are provided, but now it's to help mature the eggs and help them separate a little bit from their follicular wall so that we, as the docs, can actually retrieve them for you. The egg retrieval itself is minimally invasive. So there are no incisions on your abdomen. I have seen or had patients ask if it's like a laparoscopic surgery, if there are incisions on the belly. None. It's all minimally invasive, all through the vagina. You do also get anesthesia, and that's because there's a little needle that goes through the vagina into the ovary. You can see it here in this image, and that helps suction out the egg. Procedure itself is around 20 minutes. You see that the follicular fluid and the egg get collected into a tube. This gets handed off to our embryologist, and because the egg is microscopic, they're looking under the microscope to see, one, if there is an egg, and ultimately counting how many eggs we have retrieved. Once the eggs are retrieved, they are combined with sperm. So the sperm is actually utilized the same day because the eggs are inseminated the same day of the egg retrieval. And this is to create embryos. And then ultimately, we transfer an embryo back into the uterus, success, pregnancy, delivery, and if needed, coming back for baby number 2 or number 3. So this is just going into a little bit more detail about what an egg retrieval is. So again, transvaginal, no incisions on the belly. This is the ultrasound probe here. This is the vagina. And then we're bringing it, we're pushing really towards the ovary so that then you see here this white area. This is the needle going into the follicle to suction out the eggs. And then again, we inseminate the eggs the same day that we retrieve them. So sperm is either provided that day, or if a sample has already been frozen, we'll thaw it that day to inseminate them. 1 egg per sperm. So we call this intracytoplasmic sperm injection, or ICSI. So our embryologists look under the microscope, select out truly the best looking sperm and the most motile sperm, and inject 1 sperm per egg. So here is just a stabilizer here holding the egg in place, which is this larger structure. This is the needle that's used to ICSI, so to place the sperm directly into the egg. And so then our embryologists monitor the fertilized eggs in our laboratory over the next 5 to 7 days. So initially here we see the egg. Then we see, after it's been fertilized, these 2 pronuclei here. That's confirming that fertilization did in fact happen. The cells divide over time, and then ultimately we end up with an embryo. So that's usually day 5 or 6 of development. And at this point, chromosomal testing can be performed. So we can actually biopsy the embryos as well for chromosomal testing. And then ultimately, these embryos are frozen, actually. Whether couples are planning to perform chromosomal screening on the embryos or not, we always freeze the embryos. And that's because we've learned over the years that if we plan what we call a fresh embryo transfer, meaning that once we see that an embryo is developed, within a week, we actually put that embryo right back into the uterus. So in that same cycle that the egg retrieval was performed. We as a infertility community, not necessarily just in our clinic, but we ultimately found that it was not an ideal environment for the embryo because the estrogen levels are so high that it's higher than what an embryo is normally used to. So we freeze the embryos, allow the estrogen levels to go back to normal, and then in a subsequent cycle, ultimately prepare the lining of the uterus for implantation. So it's a combination of estrogen as well as progesterone, and then an embryo transfer. So here it's actually an abdominal ultrasound that's being performed. And then this is the uterus again, and you'll be able to see when you have that done, there's a little catheter that goes into the uterus, and then we place the embryo about 1 centimeter from the top of the endometrium. It's a 5 to 10 minute procedure. Anesthesia can be used, but is actually not necessary. And it's kind of nice actually to see it awake, just because you'll see our embryologist literally loading the embryo into the catheter. And then ultimately you'll see the docs placing the embryo into the uterus. I like to call it the shooting star. We don't actually see the embryo because it's microscopic, but we see the fluid surrounding the embryo. And I call that a shooting star. Ultimately, the embryologist takes the catheter back and looks under the microscope to really ensure that the embryo went home with you, because we want you to have it at this point. And then 10 days later is a pregnancy test. So a couple of questions that we typically get about IVF. One is, are we in any way harming your future fertility? And the answer is no. And that's because the ovaries, although they only release 1 egg a month, they actually recruit several eggs to grow in a given month. Only 1 gets ovulated, and the rest unfortunately die off that month. So really we're rescuing eggs that might have been lost already in that cycle. So we're not taking any future eggs from you. There also is not an increased risk of breast or ovarian cancer, and we're also not causing individuals to go into menopause sooner, and there's no harm to the ovaries either. In order to have even the slightest increased risk of breast or ovarian cancer, someone would have to do over 10 IVF cycles, which usually isn't common or needed. And then I did want to talk a little bit more about the pre-implantation genetic testing. So this allows us to determine the number of chromosomes in an embryo, and also, if you'd like to know, finding out if it's a boy or a girl. And this is just an image here showing, so this is the embryo. And then these cells on the periphery are what ultimately become the placenta. And you can see it's ultimately about 3 to 5 cells that are ultimately taken from the embryo, and the embryo recovers from this actually. We also have the ability to check for gene disorders. So if we know, or if there's a family history, for example, of cystic fibrosis, and we find that the intended parents are carriers, both carriers for something like that, probes can be developed, and the biopsied embryos can also be tested for cystic fibrosis as well. The next thing I wanted to talk about is also IVF, but with the possibility of using an egg donor. So for some individuals, particularly those who may be of more advanced maternal age, egg donation is another option if it turns out that one, the egg reserve is quite low for the intended parent, or if we've tried a couple of IVF cycles and unfortunately haven't retrieved eggs or haven't retrieved or obtained a normal embryo. This is also a good option for our same-sex couples, so for male-male couples as well. This actually is something that we feel very comfortable with because we actually have our own egg donor database. So we have women who are local to San Diego who have already been medically and psychologically cleared. So this actually also helps reduce the cost because there are no agency fees associated with this. But essentially what happens is the egg donor, well, couples select the egg donor. And then ultimately, the egg donor undergoes ovarian stimulation and egg retrieval. They become our patients. And then these eggs are fertilized either with donor sperm or in couples with a male partner, their sperm. And then ultimately, the embryos can be transferred back into the intended parent. It is obviously highly successful because most of the donors are less than 30. There's a lower risk of miscarriage with respect to miscarriage from chromosomal abnormalities, just because, again, these women are younger, so lower likelihood of having chromosomal abnormalities. Ideally, we have more than one embryo available and frozen, and so ultimately, patients can come back for baby number 2 or 3, and then they'll still be siblings. It can be less expensive than multiple IVF cycles, and then the intended parent can still carry the pregnancy to delivery. So at the end of the day, it's still your baby. When we're looking at selecting an egg donor, usually, again, most of our, for either whether it's from our internal program or from donor agencies in general, donors are less than 30. The other things that we have available in terms of information are the ethnicity, the race, how they look. They include photos from when they were children, their education level, what they do for work. And then they are also screened for any genetic diseases, infectious diseases. They also have a drug screen done, and a very thorough family history is taken as well. Another component of IVF can be IVF done with gestational surrogacy. So here, whether an egg donor is used or not, the intended parent can also undergo ovarian stimulation and egg retrieval, but ultimately the created embryos are transferred back into a surrogate. So this may be particularly helpful for those with a uterine anomaly, those with unfortunately repeated implantation failure or recurrent miscarriage, any medical problems where pregnancy is considered too high risk, single male couples or male-male couples. The last thing I wanted to talk about is fertility preservation, so both egg freezing and embryo freezing. So this is great because, again, I know one of the first slides going through the decline in egg number and the increase in risk of miscarriage makes it seem like you have to immediately do something. And for some couples, that's exactly what they want to do. But for other individuals, they just may not be ready or may not be certain if they want children in the future. And so, or careers may be important or travel may be important. And so this really allows us to kind of stop the clock. So this allows us to freeze eggs or embryos at a particular age, and then those eggs and embryos are frozen in time forever. So you can freeze them when you're 34, maybe you decide to use them once you're 40, and that's not a problem because the eggs/embryos will always be from when you were in your early 30s, and the uterus actually does not age the way the eggs age, so the uterus can almost always carry. The ideal age for freezing eggs really is before the age of 35. But that being said, it's not a rule or a cutoff. I've had many individuals come in after the age of 35. What changes is the number of eggs we recommend freezing. And that's because, again, taking into account the fact that the egg quality declines as we get to be in our late 30s. And so the number we'd want to retrieve is going to be higher ultimately for those over the age of 35, to take into consideration the fact that there are more eggs that can be chromosomally abnormal. We unfortunately don't have the ability to test the eggs for chromosomal abnormalities. And so that's another reason why we normally recommend, depending on age, anywhere from 50 to 30 eggs being frozen. And that may not be collected in one cycle. We may ultimately decide to do more than one cycle to get that number. With embryos, we do have the ability to chromosomally test them, and the number needed is actually fewer because although egg freezing is no longer experimental, the technique has been perfected, it's not a guarantee of future fertility because the eggs that are frozen are of unknown viability. And even if they survive the freezing thawing process, it doesn't unfortunately guarantee that it will be fertilized and ultimately become an embryo. With embryos, however, we have a lot of data, and we know that if we freeze an embryo, almost certainly will survive the freezing thawing process, and the fact that it was frozen in no way compromises its likelihood of becoming a baby or implanting and becoming a baby. We also know that the likelihood of success with embryos is anywhere from 50 to 65% per embryo. And so usually if embryos are going to be utilized, I usually say, depending on how many children you ultimately want, double the number of embryos. So if a couple wants 2 children, ultimately, I would say ideally we'd want to freeze around 4 embryos because 50 to 60% is very good, but there is still the chance, unfortunately, that implantation doesn't happen. So just to have a reserve available. Another common question we get is, how long do the frozen eggs last? Technically, indefinitely. The pregnancies that have been reported have occurred many years after the eggs have been frozen. And the duration thus far we haven't seen has not been found to impact success rates. And again, they stay at the age that you froze them. So if you froze them at 30 and you use them at 40, they are eggs from when you were 30. And again, the age of the uterus doesn't matter. So what are the next steps? I hope that this has been an informative session for you. But of course, we'd love to see you in our office just to answer more questions and really find out more about your particular history and individualized care for you. During that initial consultation, we'll take a detailed history. If you've had any other testing done, we can review those records. We'll perform an ultrasound, order the tests that we had talked about earlier in this talk, and then ultimately regroup to go through what treatment option we feel would be ideal for you, but also taking into consideration your level of comfort and what you feel comfortable moving forward with. And in the end, it's always an individualized plan for each individual patient. We also do have financial counselors that can meet with you to go through, one, whether or not your insurance covers any fertility treatment, and if it doesn't, going through what the potential costs may look like. And I just wanted to end by saying that we truly are here for you. It is truly an honor and a privilege to take care of all of our patients. And we really are committed to helping our patients achieve their family building goals. We want to provide you with compassionate care and want to make sure that it's individualized for you, and also that it's evidence-based care through ongoing research. And we're always staying up to date with new and innovative approaches. We all attend our usual conferences to help make sure we're staying up to date with the latest in fertility care. And again, we really do find it so rewarding to educate and empower our patients and ultimately support you along your fertility journey. And with that, I will stop sharing my screen, and I am happy to take any questions that anyone may have. Chat to see if we have any questions. Oh, yes, let's see. Okay. Great. So I have a question about whether or not someone with an IUD is if it's possible for them to have an egg retrieval. It's an excellent question. So the IUD does not have to be removed if you're planning an egg freeze or even embryo creation. Ultimately, if the goal is to have a pregnancy shortly after the egg retrieval, we would just recommend removing the IUD after we've obtained embryos. Another question is, what are the success rates of unmedicated IUI? That's a great question. So it depends on what the infertility diagnosis is. So for individuals, for women who have irregular periods, the goal really is to actually add on an oral medication so that ovulation can happen. So there we wouldn't necessarily recommend an unmedicated cycle. For individuals who are ovulating, we actually still would recommend the oral medication just because the studies have really shown that IUI alone, unless of course it's anovulation or a regular cycle. So IUI alone or oral medication alone doesn't really increase the likelihood of pregnancy more than continuing to try on your own. It's really a combination of the two that help maximize your likelihood of success. The other question, let me see. Questions about secondary infertility. Yes, this is also very challenging, of course, for patients just because you have been pregnant before, you've had a baby before, or you've unfortunately had miscarriages and that's been the pregnancy, and then now you're having trouble conceiving. It can be very challenging. I know emotionally it takes a huge toll. We still want to see you. We can do an evaluation. Sometimes it's a matter of the fact that maybe you're a little bit older now from the well, you yourself are not old, but that the eggs have gotten a little bit older. And so really maximizing ways to help ensure that we're shortening the time to pregnancy and helping maximize the likelihood of having a normal pregnancy. Other times we see that it may be a situation where patients have multiple miscarriages. And so also conducting a recurrent pregnancy loss evaluation as well. But just because you now have infertility, again, does not mean that you cannot conceive. It's just a matter of getting a more detailed history, getting the labs, and seeing what's going to be the best treatment option for you as well. The other question is, can the gender of the embryo be selected? Yes. So I talked about the PGT testing in the setting of just checking are the chromosomes the correct number, yes or no. But actually what you also find out is whether or not the embryo is female or male. Another question is, what is the success rate of IVF via egg donation? So that varies more from the perspective of what the age is of a given donor. Again, in general, they are less than 30. And so we'd quote the success rates based off of individuals who are doing IVF who are less than 35. So we're looking at just saying that you're doing IVF, the likelihood of success is around 54%. That's national averages. That will change and usually honestly increase depending on how many embryos we ultimately have and if we know that they're chromosomally normal. So there, the success rate per embryo now becomes anywhere from 50 to 65%. There's still a range because our embryologists actually grade the embryos. So we are also looking at embryo quality in addition to the chromosomal testing results as well. So the next question I have is choosing the gender and additional cost. Yes and no. And what I mean by that is, in order to know the gender, we have to do the PGT testing, so the biopsy on the embryo. So that in and of itself is an additional cost. And again, depending on your insurance, may or may not be covered, but our financial counselors can go over that with you. But it's not something where you're doing PGT to look at chromosomes being right or wrong. There's no additional cost to then find out, is it a boy or a girl? The other question that I have is, let's see here, sorry, just make sure I'm not repeating anything. Oh, do we always start with IUI before IVF, or are there scenarios where you start with IVF? That's a great question. Yes, so I would say it really depends on an individual patient. If it's something, for example, like unexplained infertility and the couple is less than 37, 38, we can definitely start with IUI first. Alternatively, if the couple is more closer to their 40s, we'd recommend IVF. But that being said, we always want to do what you're comfortable with. So our job is to provide you with all the information. We give you our medical recommendations, but some couples don't feel comfortable moving on to IVF. Some couples come in and say, I know that I can do IUI, but I'd rather go to IVF anyway. So the goal is really more a matter of taking your history, going through what would be the best treatment option for you, but then also making sure that it's something that you're comfortable with as well. Question about, do we do 2 embryo transfers or just 1 at a time? We always prefer 1 embryo at a time, and that's because twins are adorable, but they are medically can be quite complicated both for mom and for babies. We know that with twins, there's a higher risk for mom of diabetes and high blood pressure in pregnancy. It's not the type of blood pressure. It's not always just the type of blood pressure where we give you an oral medication and you're better. Sometimes in the more severe form, it's a situation where we actually have to induce delivery to help essentially cure the elevated blood pressure in pregnancy. And the babies do most often have to spend a little more time in the NICU. So I would say it's not a hard and fast no. It really is individualized based off of the medical history of a given patient. Oh, sorry, and then there was a question about statistics. Interestingly enough, putting in 2, if we know that the embryos are chromosomally normal, putting in 2 actually only increases the likelihood of 1 pregnancy by about an additional 10%. The risk of twins actually goes up by about 30%. And then I have another question about donor sperm banks and which ones we accept and what the success rates are. Yes, we have a list of reputable sperm banks that we work with that we'll send you. And then on top of that, the success rates in couples who, or in an individual who has no history of infertility, and it's really more a matter of having regular sperm exposure, the likelihood of success with each IUI is actually what we would quote for heterosexual couples who have no history of infertility. And so the likelihood of getting pregnant for those less than 35 is around 20% per cycle. So 20% per IUI. And then for the individual that asked about scheduling an appointment, I'm just going to take down your name and we'll look for your email about getting you an appointment scheduled. There's another question on essentially how long does a semen analysis last? We usually recommend repeating it if it's been more than a year, just to make sure that there haven't been any significant changes to the sperm. And yes, I have another question about having a consult with us. Absolutely, you can come into our office and have a consult with us. And yes, we would have our financial coordinators reach out to you and give you an estimate on cost based off of the treatment that you're looking for. Another question is, when is it recommended to move on to IVF after IUI? Usually after 4. The likelihood of success doesn't go up beyond the 4th cycle, and doesn't go up much beyond the 4th cycle, unfortunately. And so we usually recommend no more than 4. That being said, if couples are not ready to move on to IVF, we can go up to 6 cycles before reassessing at that point and talking more about IVF as well. And then, yes, a question about being out of state and virtual appointments. Absolutely. We do a lot of telemedicine, so we'd be happy to see you as well. And I think I took all the questions. If I did not, one, definitely happy to see you. And then also the other one is looking at sending in questions to the webinar link as well. And then, oh, actually, sorry, there's one more question here. Let me just read through it. Oh, this is a question about AMH, age, and recurrent miscarriage. It can be several different reasons. I will say that age, unfortunately, is a big contributor to miscarriage. However, there are other things that can contribute to miscarriage. There are autoimmune conditions, chromosomal abnormalities unrelated to the egg, and also hormonal imbalances. So I actually would recommend a consultation so we can order some additional testing to then work it up from there. The other part of the question is the impact of PCOS. Yes, unfortunately, we also see that PCOS in and of itself may contribute to miscarriages, but there are things that we can adjust in your treatment protocol to help minimize those risks as well. Thank you. We did take all of them. And if I didn't, if I missed your question, I apologize. But I'd definitely be happy to see you. Again, thank you all so much. It was such a pleasure speaking with all of you. Thank you for taking time out of your busy schedules. And I hope to see you in a consultation soon.